Hello guys, welcome back to my channel Connect Radiology. So in this video we are going to discuss about the imaging of adrenal incidentalomas. So in this video we are going to discuss what's next when you get an adrenal incidentaloma on NCCT scan. Okay, so we are not going into this that whether the adrenal incidentaloma is functionally active or not, whether they are secreting any hormones or not, but we have to decide whether the lesion is potentially malignant or not when we are getting these lesions on NCCT images. Okay, so the very first thing on NCCT image you have to see is the Hounsfield units. If the HU of the lesion is equal to less than 10, the lesion is homogeneous and of any size. Okay, next, no further imaging is required because these lesions are usually benign. Okay, the next thing is the lesion is homogeneous, the HU is between 11 to 20 and the tumor size is less than 4 centimeter, then we have to go for, we cannot characterize these lesions on NCCT images, then we have to go for additional imaging, and these additional imaging can be either FDG PET CT, that can be adrenal MRI with chemical shift imaging, or that can be adrenal protocol CT with washout phases. We will discuss this later. Okay, we have to go for any additional imaging to further characterize them, or what we can do is interval imaging in 12 months with non-contrast CT or MRI. Okay, so these three are the criteria. The lesion is homogeneous, the lesion is having HU between 11 to 20 and the size is less than 4 centimeter. Remember, this size cutoff of 4 centimeter is very important in adrenal lesions, because lesser the size of the lesion, lesser is the chance of malignancy. More the size, more is the chances of malignancy, and also smaller the lesion is, the better surgical prognosis is there. Okay, so tumor size is very important in adrenal. Next is what is classified as indeterminate adrenal masses. So if the lesion is homogeneous, okay, the lesion is homogeneous, HU is between 11 to 20 and the size is more than equal to 4 centimeter. Okay, the lesion is homogeneous, the HU is more than 20 but the size is less than 4 centimeter, or if the lesion is heterogeneous and size is less than 4 centimeter. Okay, so these are the indeterminate adrenal masses. Again, we have to discuss with multidisciplinary teams, and we have to consider for additional imaging, that is again the FDG PET CT, chemical shift MRI or washout CT protocol. Next is, what if the tumor is more than equal to 4 centimeter, the lesion is either homogeneous with HU of 20 or the lesion is heterogeneous. Okay, tumor size is more than equal to 4 centimeter and that can be homogeneous with more than 20 or heterogeneous. Okay, so generally these cases are also discussed with multidisciplinary teams, and if there is history of cancer, we have to look there is any cancer history present. If their cancer history is absent, then we can straightforward go to surgical options, because more the size of the tumor, more is the chances of malignancy, so we have to operate these patients. And if there is history of cancer in the patient, then what we can do is PET CT, or we can go for biopsy of these lesions. Okay, I hope this approach thing, what to do next, is clear to you. So whether we are giving a clean check to the patient, no further imaging required, or we are directly taking the patient for surgery, and in between these two lies the patients who need additional imaging. Okay, these groups that include that require additional imaging are these lipid poor adenomas and the pheochromocytoma, adrenal cortical carcinoma, metastasis. Okay, we cannot characterize these lesions on NCCT images, so we need additional imaging to characterize them and take further decisions. That can be either imaging follow-up, that can be a biopsy, that can be PET CT, or that can be resection. Okay, the first clean sheet that we gave to the patients, that are benign lesions. Okay, and they are typically benign. For example, I already told you that when the HU is less than 10, they are benign because they are usually the lipid rich adenomas. Okay, if the HU is less than 10, equal to 10 HU, or there is signal drop on opposite phases images, that can be myelolipoma, where there is macroscopic fat, there is blob of fat in the lesion. We'll discuss this later. That can be either a cyst with water density and no enhancement. That can be a benign calcification. That can be coarse, curvilinear, or septal. We'll discuss this later. I think we'll discuss this later. Okay. So for now, I think this approach thing is clear to you. Now let's discuss what's next.